Hello everyone, welcome back to the channel. Today we're going to learn about Myasthenia Gravis, which is the next in the neurology series. So Myasthenia Gravis is an autoimmune condition that results in poorly functioning acetylcholine receptors. So essentially these acetylcholine receptors are usually released from a presynaptic neuron. They travel across the synaptic membrane and then attach to receptors at the postsynaptic neuron, from which an action potential is initiated and goes to the muscle, allowing for muscle contractility. But in myasthenia gravis, there are these autoantibodies against the acetylcholine receptors, which block and bind to and block the receptors, which means you can't get the transmission of the acetylcholine, and therefore the action potential is not released, and therefore this reduces muscle contractility and increases muscle fatigue. It's a condition that is more common in women, in particularly women below the age of 30, but it can also present in men, especially men over the age of 60. It's typically associated with a cancerous mass in the thyroid called thymomas, which presents in about 15% of individuals. And it can also be associated with other autoimmune disorders, as particularly systemic lupus erythematosus, rheumatoid arthritis, pernicious anemia, autoimmune thyroid disorders also, and thymic hyperplasia, where the thyroid gland becomes enlarged. Now, typical presentation of myasthenia gravis would include muscle fatigue, and this particularly worsens with activity and improves with rest. So it may worsen throughout the day and improve in the nighttime when the patient isn't moving around as much. And this is a contrast with another condition called Lambert-Eaton myasthenic syndrome, which presents in a very similar way as myasthenia gravis, but actually improves with exercise. You can also get extraocular muscle weakness, which can lead to weakness of the eyelid muscles, leading to ptosis, which is drooping of the eyelids, as well as diplopia or double vision, as well as proximal muscle weakness of the muscles of the face, the neck, and the limb girdle, leading to weakness down along the arm, as well as difficulty and weakness in swallowing, leading to things like difficulties with chewing and dysphagia. So to investigate further, we can do a series of bedside examinations, bloods, and imaging. In terms of bedside, we want to examine the patient. We want to look for any things that may be a risk factor and that can indicate myasthenia gravis, such as a thymectomy scar, as well as things that may exacerbate myasthenia gravis in the patient's history. So we're looking out for exacerbating factors, such as things like if they're on any beta blockers, lithium, quinidine, or penicillamine, which are all drugs that can exacerbate and worsen myasthenia gravis, as well as antibiotics such as gentamicin, macrolides, quinolones, and tetracyclines. Upon examination, asking the patient to look upwards can also worsen diplopia. We can do a various test, especially the tensilinals test, which is when the use of IV edrophonium helps reduce muscle weakness temporarily, and this can indicate myasthenia gravis. In terms of bloods, we want to take a full blood count and in particular look for specific markers such as creatinine kinase and acetylcholine receptor autoantibodies in the blood, which can indicate in raised levels myasthenia gravis. We also want to do a kind of test called the electromyography, single fiber electromyography, and also a CT scan to look for and exclude thymomas. To treat and manage myasthenia gravis, we want to stop any drugs that may exacerbate it, such as lithium, such as beta blockers. And this is because beta blockers can increase bronchospasm and reduce the forced vital capacity of the lungs, and worsen a condition called myasthenic crisis, which is essentially a exacerbated and worsened myasthenia gravis where there is respiratory failure due to weakness of the respiratory muscles. And if a patient ever presents with myasthenic crisis, they will automatically need to be mechanically ventilated and given plasmapheresis and immunomodulator therapies intravenously to treat them. In terms of the long-term medical management, we want to give them a long-acting acetylcholinesterase inhibitor, which will help to reduce the breakdown of acetylcholine in the neuromuscular junction, and therefore this first-line treatment can help to temporarily improve the symptoms of myasthenia gravis. The first-line example being pyridostigmine, and second line we can also use neostigmine. We'd also want to use immunosuppressors to reduce the autoimmune effects of the condition. Some examples of drugs we can use include azathioprine, cyclosporine, myclophenolate mofetil. And in terms of surgically, we can help remove any phimomas through surgical procedure called thymectomy. As I explained before, a common complication of myasthenia gravis if not treated is myasthenic crisis, when there is a weakness of the respiratory muscles leading to respiratory failure, and this can lead to death. So this is a very common and dangerous neurological condition that we really want to tackle and improve and treat as soon as we can to help to improve the quality of life of the patient. Thank you so much. If you have any questions, please feel free to comment down in the section below. Thank you.